Well, good morning, everybody, and welcome to the Systems for Action Program Research in Progress webinar. Thanks so much for joining us today. We're in for a treat in that we're going to hear some updated research in progress from our colleagues in the Chicago Collaborating Research Center of the Systems for Action Program. Regular listeners of this Research in Progress webinar have heard from the Chicago team a number of times in the past. They've been very gracious with their time and giving us regular updates about what we're learning from the Comprehensive Care Community and Culture Program, the study of that program in Chicago. And so, and they've agreed to yet again give us another update from their study and what they're learning. So very, very dynamic set of studies that are underway in Chicago. So we're eager to learn even more about what's going on with their S4A findings. So we're very fortunate to have Dr. David Meltzer with us today. He is one of the leaders of the Chicago team that's studying the C4P intervention. Dr. Meltzer is a professor of medicine and public policy and economics at University of Chicago, and has his hands in a number of areas of research related to both health as well as public policy. And so I think Dr. Meltzer is going to lead us off today. I know we have other members of his research team in Chicago also with us. And we're also very fortunate to have Walter Kindred with us as well, who's another collaborator with the Chicago team in the study of the C4P program. Walter is president of the South Shore Cultural Center Advisory Board, and is also a patient with the Comprehensive Care Community and Culture Program in Chicago. So he really played a key role in both helping to design and implement the study, disseminate findings, and also obviously has an on-the-ground view of an experiential view of the program and its effects. So thanks for joining us, and I will turn it over to Dr. Meltzer.
Great, Glenn. Thanks so much for giving us the opportunity to present again. This truly meets the title of Research in Progress. We're going to show you some new results that are so new that not everyone in the room even here has seen all of them. But I hope that will be useful for many. And I'm also going to review some of the earlier work, so those who haven't been part of it will have a sense where we're coming from, because it really kind of all fits together as a group. So, and I'm super glad that Walt has joined us. He really is a true partner in this. He's also a patient in the program, as you mentioned, and mostly a wonderful partner and true friend. So this is me, and this is Walt, and this is our presentation. So as you said, I'm going to talk about our Comprehensive Care Community and Culture Program. I'm going to focus on the results with respect to the effects on patient activation and hospital admission. And like all our work, this is focused on a particular subgroup of patients who are Medicare patients and at increased risk of hospitalization. And the subtitle says Findings of a Randomized Trial. I should probably say Initial Findings of a Pilot Trial would probably be a more appropriate title, but you will find that out soon enough. So let me begin with a little bit of background. And as I said, I'm going to try to frame this initially in terms of our comprehensive care program and then lead into the C4P program. And I think everyone knows that, as the U.S. tries to control healthcare costs and improve outcomes, focusing on these patients who are at high risk of hospitalization is really critical. We know that a small fraction of patients account for a large fraction of healthcare spending. And we know that hospitalization-related costs are a large fraction of these costs. And we also know that improving coordination of inpatient and outpatient care is really a key opportunity for these groups. And you'll see that these programs are targeted towards that. In addition, one thing we've also learned is that socioeconomically vulnerable patients may be particularly at risk of care coordination problems. And so that's a group we really focus on. At the same time, health policy is changing. We know that payment models are increasingly aligning incentives for improvement. And so things like readmission penalties, ACOs and shared savings, capitation are all setting us up with incentives to try to deal with these care coordination problems. But we've also learned that solutions are not easy. And I think we see that through a review of many care coordination programs. This is a review of Medicare's efforts in care coordination programs over many decades. This review is dating back to 2012 now, but I think the message is still clear that although some of these programs have shown decreases in hospitalization rates, many of them have shown increases in hospitalization rates. And the conclusion overall is that these things do not do a great job of reducing hospitalization and rarely recoup their costs. Most of these programs are based on hiring care coordinators, and the programs tend to work a little better the more interaction there is between the care coordinators and the physicians, or the care coordinators and the patients. But by and large, even when the interactions are strong, they don't really save money. And one is left with the general sense that it's sort of a game of telephone where one person is trying to get information to another person and to another person, and those communications are costly and error prone. And so if you look in the bottom right here, you see some bars of reflecting our expenditures. And right now we spend a lot of money on hospital care and a little bit of money on ambulatory care. We want to shrink that bar. We try to do it by providing care coordination. That costs money, so we got to carve out part of that bar to pay for that. We still need ambulatory care because it's keeping people out of the hospital, and that means if we're going to shrink that bar, we got to shrink hospital care a lot, and that is just really hard to do. And so that is, I think, one of the reasons why these programs haven't worked that well. Into this mix come hospitalists, doctors who specialize in inpatient care. This is a change from the traditional model of primary care doctors in the OC cared for patients in and out of the hospital. When this got started, we hoped they would improve care and lower costs. We emphasized the advantages in terms of inpatient expertise and presence, but also recognized substantial disadvantages, including discontinuities of care, loss of the doctor-patient relationship. And the conclusion that we and others have come to is that the net effect of these changes in terms of costs and outcomes were really pretty modest. So this left us with the question, if hospitalists really aren't so much better, why did they grow so quickly? And part of it surely is the belief that they would be better. But there's a second theory that's really arisen in our mind as well, and that is that hospitalists grew because of the needs of primary care. That over time, there were declining hospital volumes compared to ambulatory volumes, and that made it harder for traditional primary care doctors to do the job they used to of seeing their own patients in the hospital in the morning and in the afternoon in clinic, because they just were too busy in clinic and didn't have enough patients in the hospital every day to justify that trip. And this got more and more sort of striking over time as there was declining hospital use and maybe even more importantly, increases in ambulatory use for preventive care, which meant the doctors could be very busy all day long and just not have patients in the hospital. And then as physicians organized in groups, it was natural for them to pass off their inpatient work to one of their colleagues, and this sort of led to the growth of the hospitalist movement. So this sort of insight was really important in shaping our work, and it really had at its base an ambulatory economics theory of hospitalist growth. And both Harold and I are trained as economists, so we use those tools in our work, and this was no exception. We compared the time costs really of two models, a traditional model where the internist spends their time seeing patients in the hospital and clinic and then has to drive between the two, and this newer hospitalist PCP model where the hospitalist spends their time seeing patients in the hospital, but now they have to communicate with the PCP, and the PCP spends their time seeing patients at clinic, and now they have to communicate with the hospitalist. So the difference in cost between this newer PCP hospitalist model compared to the traditional model is driven by per capita communication costs relative to transport costs for a traditional internist. And the math here is just a mathematical way of formalizing that. But the key lesson that comes from this is that the cost of this newer model compared to the traditional model falls. In other words, the newer hospitalist model becomes attractive when there are fewer admissions relative to the number of ambulatory visits. So you're seeing healthier people in clinic, which we just told you was happening. As communication costs decline, so it's easier to call the hospital than to go. As transport costs rise, hospitals get bigger and further away and harder to get in and out of the garage, and as physicians work fewer hours so that they have less hours available to do the jobs of both seeing patients in clinic and in the hospital. So those were what the theory said, and the Marcus Welby pictures there on the right are pictures of him, this famous TV doctor from the 1960s, illustrating all these trends, seeing healthy patients on the phone, unhappy driving, and the motorcycle is symbolic of his new colleague wanting to work fewer hours, which Welby did not approve of. So those are sort of anecdotes, but we actually took all these concepts of falling ambulatory visit rates, admission rates for ambulatory visits, communication costs, transfer costs, and physician work hours, and using the community tracking study, we're able to show that these variables did a really good job of predicting which primary care doctors gave up their practices to hospitalists. So it concluded that sort of the hospitalist model grew basically because it was easier for doctors. Now, you could just accept that and say this old model is no longer efficient and we shouldn't have it. But what one loses is the value of the doctor-patient relationship. And there is this very rich literature showing how important that relationship is in terms of trust, interpersonal relationship, communication between the doctor and the patient, knowledge of the patient. We know patients value seeing their own doctor in the hospital. There are observational studies that show lower costs and better outcomes with continuity of care. So, for example, Medicare patients cared for by their own doctor for more than 10 years have 15% lower Medicare costs. Lung cancer patients cared for by their own doctor in their terminal hospitalization have 25% lower odds of ICU use, presumably futile care. These are observational studies. There's one striking experimental study done by John Wasson in the VA in the 1980s, where they randomized complex patients either to see the same physician in every visit or a completely different physician in every visit. And in this continuous care group, they had really remarkable results. 49% lower emergent hospitalizations, 38% lower hospital days, 74% lower ICU days. So this really tells us that this discontinuity is incredibly harmful and costly, especially for complex, frequently hospitalized patients. And it raises the question of whether better coordination of inpatient and outpatient care could improve outcomes. But is there a way to do it without offsetting any savings, as we saw was the problem before? And this is what set us up for our sort of basic work that led to the C4P work, the Comprehensive Care Physician Program, or CCP program. And the idea here is that if the problem for doctors in doing the old job is they don't have enough patients in the hospital on a given daily basis, we can stratify patients according to expected hospital use. And for those who are at high expected hospital use, they can get a comprehensive care physician who will see them in both places. And because they're only seeing patients at high risk of hospitalization, their clinic panel can be much smaller, 200 or 300 patients versus the 2,000 or 3,000 cared for by a usual doctor, primary care doctor. And that panel can be small enough that the doctors can give them all the care they need, seeing them only in the afternoon, and yet have the morning free to see patients in the hospital. And that's the basic model that we'll talk about. For those at low expected hospital use, they rarely get hospitalized, and so we don't need to worry about them so much with respect to inpatient-outpatient continuity issues. It's okay if they get a hospitalist. In the rare instance, they're hospitalized. But for those getting the CCP model, what are the advantages? Most frequently hospitalized patients get their own doctor in both settings. This continuity is valued by patients. It can decrease unnecessary testing, treatment, and errors. It much lowers the doctor's costs, not just in travel, but in history taking. You can walk into a room right away, and instead of getting a whole history from a patient, just find out what happened to bring them there and have that relationship already. All hospitalized patients get doctors with significant hospital experience and presence, so all the advantages of being a hospitalist. The physician can even be a specialist. Patients can choose their doctor, which they can't with a hospitalist. This is a model that can work practically for the physician with a smaller panel size. And from a health system perspective, with payment models, you could use this in a patient-centered medical home, bundling, readmission penalties, or if you've got a hospital with empty beds, instead of building a huge network of referring physicians, you can have a small number of these doctors who can help fill those beds in the hospital. what are the challenges? Will patients be willing to switch? Will doctors let patients switch? Will doctors even do this job? And can it be economically viable? So those are some of the questions we had. We were funded in 2012 by the Center for Medicare and Medicaid Innovation to actually build this program out at the University of Chicago, which cares, at least on our general medicine services, for a very socioeconomically vulnerable population. And then from 2012 to 2016, we did a randomized trial where 2,000 patients were assigned either to the who were Medicare or dual eligible patients were assigned to either the CCP model or standard care, where they had a different physician in and out of the hospital. And because patients had to be willing to switch in order to enter the study, we knew their doctors at baseline might not be great, or they might not be very happy with them. So anyone who was in the control group was offered the ability to get a new physician, and we would help them do that. And so the goals of the study were really to figure out whether offering these patients at increased risk of hospitalization access to a CCP compared to standard care improved outcomes over 1 year, including patient experience with health care, which we measured with satisfaction with the provider, health outcomes, including both self-rated general health status and mental health status, and then resource utilization, including patient-reported hospitalization rate and Medicare claims. And we'll focus mostly on the patient-reported part in what I'll show today. So these are some of the key elements of the original model. We focused on patients at increased risk of hospitalization, which we measured most simply by have you been hospitalized in the past year, and we recruited them in the inpatient setting, in the ER, through a variety of other approaches, including people whose doctors were leaving the institution. We kept the panel size small at about 200 patients per doctor. They spent their mornings on the wards, a little time off in the middle of the day, and then in clinic in the afternoon. We built a very tight interdisciplinary team organized around these 5 CCP doctors, each of whom saw patients in the morning and then in the afternoon were in clinic and covered for each other on afternoons and weekends, and then a very tight multidisciplinary team involving nursing, social work, and so on. We kept these teams small and well-connected to keep costs low and promote interaction with things like multidisciplinary rounds. We focused on care transitions with post-discharge calls and health IT. We began under fee-for-service, but also got ourselves set up to do shared savings. We tried to really support the members of the team so they had sustainable roles. It's a highly morbid population. We used rapid cycle innovation techniques for improvement and a rigorous evaluation, as I said, with this 2,000-person randomized trial. So the data for the evaluation came from patient-reported data that was done in a baseline survey prior to randomization, and then quarterly surveys. We collected patient demographics and then these measures of care experience, health status, and hospitalization that I mentioned earlier. The analysis began with comparing baseline demographics and health status measures. We used longitudinal mixed effects models, either LOGIT or zero-inflated Poisson, depending on whether we were looking at health status or number of hospitalizations. We used random intercepts to account for repeated measures in subjects. We used a number of covariates, including age, gender, dual eligible status, ethnicity, a number of hospitalizations at baseline, and we used pattern mixture models to address missing data and deaths, although we actually had very high follow-up rates typically. But we did use the pattern mixture model approach. So these are the baseline demographics between the CCP and the control groups in the original study. You can see here that they're very well matched in terms of all the attributes in the table, age and gender and race, and on the right side, health outcomes. There were some small differences between these, but none of them statistically significant. And then here are some of the results. So this is physician ratings. At baseline, on the far left, you can see that the CCP got slightly higher ratings than the standard care. These were the patients entering the program, I should say, rating their prior doctors. But that was not statistically significant. We controlled for those regardless in doing the multivariate analysis. And what you can see is that after that point, with the first, second, third, and fourth wave, so 3, 6, 9, and 12 months, standard care improves. Actually, when they both start out there, they're both around the 20th percentile nationally in patient satisfaction. The standard care goes up to about the 80th, and that's because we help them get a new doctor. But the maroon line above that goes to the 95th percentile, and it stays at that point throughout the study, and those differences are highly significant. So CCP patients were way more happy with their doctors, and that indeed is what we heard from qualitative reports as well. This is general health status. No significant difference at baseline, although CCP patients seem to be a little sicker at baseline, but no differences after randomization. So we didn't seem to move general health status. On the other hand, mental health, again, no statistically significant differences at baseline, and then in the periods after that, highly statistically significant improvements in mental health rating. Then this is follow-up hospitalizations. This is kind of the key slide really from a health system perspective, and in many senses also from a patient health perspective. No statistically significant difference at baseline. In fact, CCP just a little bit higher in hospitalizations. And then after that, declines in hospitalization rates for both. That's regression to the mean to some extent. But if you see the maroon line is well below the gray line, so CCP below standard care, and that's about a 20% reduction in hospitalization sustained out to a year. And we have subsequent data that suggests those savings reductions go even further. So let me try to summarize this baseline work, and then I'll get right to the C4P stuff. So, when we started the CCP study, we didn't even know we could build it, and it was indeed possible to implement it, and we found these positive patient outcomes and acceptable volumes for clinicians, and also acceptable return on investment for the hospital as we did those analyses. We found that the CCP care improved the patient experience and at least maintained patient outcomes while reducing hospitalizations about 20% up to a year. The number needed to treat was enrolling about 4 patients to prevent 1 hospitalization over 1 year. So in our study, we estimate that we prevented about 250 hospitalizations over 1,000 patients in a year. We estimate that implies about $4,000 savings per patient per year, and at a programmatic level, that comes out to about $4 million per year, which cost way more than the program costs. In fact, in many ways, the delivery costs themselves for CCP come very close to zero. Limitations, self-reported outcomes are what we're analyzing here, and they could be biased by patient report or less than complete follow-up. We did not have complete Medicare claims data to analyze hospitalization and costs, although we had partial data for the first part of the study, and we found evidence that is similar to what I told you. We did have a problem with dual eligibles who are more likely to drop out of the study due to the Illinois Medicare-Medicaid Alignment Initiative, especially the healthier patients. The sicker ones tend to stay with us because they wanted the care they were getting from their doctors. And that does produce some bias in parts of the claims data. Other limitations, this was a new CCP program, 1 hospital, a limited set of doctors, and a socioeconomically disadvantaged population. So this is really a very lengthy background for what is the core study, which I'll now get to. And that is probably relates to the most important limitation of the CCP work. And that is there's an incredible need for improved engagement. And so about 30% of patients were randomized to CCP, never really engaged in the program, despite our efforts to reach and engage them. They didn't make appointments. They made appointments, but they didn't keep them. And there were other ways in which they might not engage, like not taking medications, for example. And all these forms of engagement that could be improved create opportunities to benefit patients and lower costs. And we knew that these patients who were not engaged were very frequently admitted, and the average cost of $75,000 to $100,000 a year, if anything even higher than some of the patients who engaged. So why do they not engage? This was the key question we wondered as we thought about our original work with RWJ. We looked at demographics. They were diverse in many ways. Some were young, some were old. Some patients who didn't engage were well. They didn't care about this. Others were too sick. The one constant seemed to be low income, low social support, and a history of low engagement. And we did some qualitative work to look at this, and if there's one quote of all of them that to me sort of says it all, it's this one from one of the people we talked to early in the study. And they say, if I had transportation, I wouldn't have a problem getting up. I don't know if it's just depression or what, but a lot of times I just don't want to be bothered. It's been like that a lot. And so it's this complex interaction between resources and unmet social needs and the patient's sort of psychosocial state. And that, in a lot of ways, what motivated our design of the program. So let me now turn to the Comprehensive Care Community and Culture Program, or C4P. So the basic idea was we began with the CCP program, the same doctor caring for you in and out of the hospital. But our goal was, following the sort of RWJ culture of health approach and systems for action in particular, to try to align resources across sectors by identifying and meeting patient needs and activating them to ultimately engage in their own care. And so there were three elements of the program. The first was systematic screening for unmet social needs, for which we did with a Health Leads instrument that covers 17 different domains of unmet social need. Then access to a community health worker to engage the patient and connect them to resources. And then finally, access to community-based arts and social programs to try to activate the patient, get them engaged in promoting and believing they can promote their own care. So that was the idea. Here, in a sense, is our conceptual model for this. We begin on the left with these high-risk patients who may or may not be activated to engage in their care. If they are activated up on the top, then they go ahead and they are offered CCP and they take it up and they get improved outcomes. On the other hand, if they're not activated, they end up on the bottom here, and they wouldn't get CCP if left to their own devices. They just wouldn't take it up. But we add with C4P these added elements of screening to identify unmet social needs, community health worker, and the Artful Living program, which is our community-based arts and social program. And that then hopefully activates them. They then get access to CCP and get improved outcomes. So that's kind of the concept behind what we're trying to do. So I'm sorry, this should say C4P study at the top rather than CCP study. So we began in 2016 with funding from RWJ. We established the C4P program at the University of Chicago. From August of 2016 to February 2019, we randomly assigned 526 Medicare and dual eligible patients at increased risk of hospitalization to C4P versus CCP versus standard care with different physicians in and out of the hospital. And again, this helped to find a new doctor if desired. Our goals were really twofold, and I'll lead you through some of the results of each of these. First, to gain experience operating C4P because we'd never done this before, so operational experience, and then also insights into these patterns of unmet social needs and the implication of that for program design. And then secondly, to do this pilot assessment of whether offering Medicare patients at increased risk of hospitalization, the C4P program compared to CCP or standard care actually affects outcomes over 1 year, including patient activation, which we measured using the PAM or patient activation measure, and then the variables we've looked before, patient experience, health outcomes, and resource utilization. And when I get to that aim, I'll talk mostly about patient activation and resource utilization. Okay. So let me start with this first aim of gaining experience with operating C4P, and as I said, operational experience and insight into unmet social needs. So I think there were a couple of key operational lessons. The first was that iterative development of the program elements was critical. We had to recruit and train the team, identify community health workers, social workers. We had to develop the team roles and responsibilities, workflows, tools, resources for all of them. And it took time to figure out, even as quickly as we wanted to work, given the time frame for the grant. It was also critical to engage patients in the program, to refine the intervention. And we took a very iterative experimentation approach where we would try to design events and see if patients were interested and found them valuable, and then get suggestions about how to improve them. And one of the challenges in doing that is because this was designed as an RCT and we started out recruiting patients, we originally had very small numbers of patients. And so we had to sort of recruit people to run the program to refine it. And that sort of initial critical mass of patients was essential. In fact, some patients were especially engaged and impactful. Walt, although not a C4P patient, a CC patient, is an example of perhaps the best example of a patient who's been really someone who's helped us shape and run the whole program. The other important thing is that standard care was not static. Over the course of this time, our institution became an accountable care organization for Medicare, and they wanted to begin to move into using care coordination models for standard care, and so we had to deal with that. With all those challenges, I think we in the end concluded that engagement really was possible. About 30% of patients who entered C4P and had been in the program for more than 3 months actually have engaged in the arts and social programming. We do have many regulars, but interestingly, they're not necessarily more socially engaged otherwise. In many social programs, it's the least needy who engage the most. But we've actually found that many of the people who get engaged are people who don't have these other outlets. We do find, though, that sort of health and psychosocial barriers to engagement are really important. It's not uncommon that you schedule an event and a number of people say they're going to come, and then several of them are in the hospital by the time the event comes. So there are challenges in this group. One thing that was striking is we had very high rates of use of our community health worker and social worker. About 68% of all the C4 patients actually engaged with them. I also want to highlight that the unmet social need data we got was really highly informative. And some of this I've presented before, but I think it's useful for people to see. These are the 17 domains we screened for unmet social need. The first 16 are part of the original Health Leads assessment. That was a group that started using students to help address unmet social need. We added the 17th domain, which is spiritual or religious support, and because our patients told us this mattered to them. And you can see the list is incredibly diverse: food, housing, money, employment, safety, social isolation, so on. One of the striking lessons when we looked at this data is that although the needs were incredibly concentrated in a small fraction of the population, 59% of respondents had only 0 to 2 unmet needs, accounting for only 13% of total unmet needs. The other 41% of respondents accounted for 87%, and 24% of the respondents had 5 or more needs and accounted for 67% of unmet needs. And so this means that most unmet needs are in people who have many unmet needs, and one of the challenges that our patients told us is it's hard enough for them to get to one provider to help address a need. Getting to many is just absolutely overwhelming. So we tried to look as early as possible at sort of how do we address needs, more jointly. So we ended up doing eventually a latent class analysis to look for clusters of unmet needs. And we found sort of 5 clusters of unmet needs. Going from right to left, so opposite as usual. On the far right, there's a cluster of people which basically have very few unmet needs. And then next to that is a smallish cluster, unusual cluster of people who have children, child-related, and legal needs. The next 3 clusters are really interesting. The third column there is unmet financial need, money, health insurance, transportation. Then the next one to the left of that is sort of healthy living and physical activity. And then in the very first column there, where you see all the green, that is sort of the many basic unmet social needs. And so this latent class analysis eventually informed our approach to what is now our Wave 2 C4P project, where we designed interventions organized around these many basic unmet needs: healthy living and social engagement, insurance, child-related needs, and we didn't feel we needed to do much for those with few unmet needs. So let me turn to the second aim and show you a little bit of the data for our pilot assessment of whether providing patients C4P versus CCP versus standard care affected outcomes. And as I mentioned earlier, I'm going to focus on the patient activation results and the resource results, particularly patient-reported hospitalization. So these are the baseline attributes of the C4P subjects, and they're pretty well matched across the board. You can see there are a few differences that we think happened just by chance. A few more dual eligibles in the CCP program, but interestingly, the CCP program also, or ARM I should say, also had people who were a little more activated at baseline. Not much, but apparently enough to give you a p-value of 0.05. So not striking differences, but one thing to remember is our previous study we had 1,000 patients per arm. This one is more like 180 patients per arm, so much, much smaller. And that as I said, it was a pilot, and those small sample sizes won't matter, as you will see. So again, our conceptual model was that C4P would help activate these unactivated patients, and so the program overall would be more effective. And these are some results that show you the effects on hospitalization rates and on the PAM. And I've highlighted in this version of that same slide some of the effects. And the p-values are occasionally less than 0.05. They're sometimes more like 0.1 or even a little over that. But it's quite striking. We saw that the C4P arm compared to standard care had this trend towards about almost 30% reduction in hospitalization rate. And actually compared to CCP, it looks like C4P had even larger, about almost a 40% reduction the first one's about 30%, the second one's about 40% reduction in hospitalization rates. The PAM is this measure of patient activation, and here you can see the C4P patients had these increases in activation. Whether that was measured as being at the highest level of activation, there are 4 levels, and these are level 4, so that was a significant increase, or the continuous score of about 5 points, and this is on a scale of about 60. So one thing that's striking is the C4P had more increases in activation, but note that even the CCP patients had a trend towards increased in activation. So I think, maybe that's the doctor-patient relationship, maybe it's nothing. Again, these samples are small, but it was interesting data from the pilot. Now, remember, our theoretical model said that these activated patients are going to do well anyway, but these unactivated patients are the ones who should really benefit for C4P. So we decided to do some analyses breaking that out. And we also had done some earlier work suggesting that in general, patients who'd been hospitalized more did better when they got the CCP program. So we looked at that too. So, this is the key slide where these things are highlighted. And what you can see here is we've now added a couple of rows to the slide we had before. First, high baseline hospitalization and low baseline hospitalization. And what you can see is, by and large, in the high baseline hospitalization group, you see bigger effects of C4P and also CCP. In fact, in the low baseline hospitalization route, CCP doesn't seem to do much at all, which is sort of what we'd seen before. So, nevertheless, we again see that in these subgroups, C4P seems to have this advantage. It's also striking when you go down to the row that says low baseline PAM. So these are the not very activated patients. You see, again, a trend towards the C4P patients having bigger benefits compared to the row right above that where you're really not seeing anything. And the sample sizes here are getting truly tiny. Like, this is less than 100 patients per group. So the best you can hope for on this is to really look at trends. It's kind of amazing we're seeing anything significant. You do have to think about multiple comparisons, those sorts of issues. So I don't want to oversell these results. Again, this was a study done not to prove effectiveness, but to get experience doing this. But I think these trends are super exciting. These are some graphs showing these trends over time. And, this, again, is cutting the data very finely. What you can see is that, it looks like at least in the first few periods, the dark 2 lines, the darkest is C4P, the black, and the red or maroon is CCP, are above the standard care and activation. You see some bouncing around at the end, which looks, different from that. One of the challenges that we had in the study that we should talk about is that if you look at the numbers of subjects in each wave, you'll see at the first wave they're fairly similar, and at 3 months they're fairly similar. And by the time you get to, say, 9 months, the standard care wave group has fewer patients. So we had more dropouts in those. And we think that had some effect on some of these measures as well. And the reason we think this happened was that the surveys were just really long, and the CCP and C4 patients would put up with it, but the standard care patients just really didn't. And so we think that the patients who actually stuck with all of this were ones who were more engaged in general in their care and may have been more activated. You can see that was the extreme measure of high levels of activation. The pattern was a little less striking when we looked at continuous measures, but quite similar. And then when we looked at follow-up hospitalizations, I think the key thing here to focus on is probably the difference between the CCP arm and the C4P arm, in other words, the red line and the black line. And you can see that, even though the confidence intervals are very wide here, the CCP arm, the C4P arm is below the CCP arm. I will point out that there were some baseline differences, not significant, but that we control for those in the later analyses. So the trends that you see here don't just reflect those baseline differences, because those have been controlled for. Then in the next slide, we've stratified by baseline numbers of hospitalizations. The left panel is the one with more hospitalizations at baseline. And here you can see, again, sort of C4P well below the CCP. And those both have, pretty high follow-up rates. So that's kind of consistent with the trend we expected. And then, again, here, the same thing, but now with activation. And again, bigger effects on the left panel with the black line below the red line, and this is the greater activation. So we're pushing the data very hard here, but some trends that look like kind of what we expected. So some conclusions and limitations. And we found it was critical to sort of iteratively improve these C4P operations. We were successful in engaging patients. Even in a small pilot, we found at least some evidence of reduced hospitalization, increased activation with C4P versus CCP in standard care. We obviously need more sample size to really look at this. We need to get claims data. We also learned some important lessons about excess survey burden, especially for standard care. And so as we now prepare for our next set of work, we've cut the survey lengths by almost 50% so that hopefully we can get higher response rates. We did see these evidence of sort of larger benefits of C4P versus CCP and patients who are less activated at baseline. We sort of saw comparable estimates of C4P versus CCP in patients with low or high baseline hospitalizations. This has led us to think about the potential benefits of C4P in somewhat lower risk hospitalization, risk of hospitalization. And so we're actually expanding our population a little bit to somewhat lower risk hospitalization groups, partially in response to that. Next steps, we're busy completing the analysis of CCP and C4P at UCM. We're looking at long-term follow-up. We've been funded by the Donahue Foundation to do that in CCP, with looking at cost, duals and non-duals, hospitalization risk, doing qualitative assessments of the doctor-patient relationship in CCP, and also end-of-life care. For C4P, we're completing this analysis of unmet social needs data, including over time, and analysis of outcomes data. And then we've begun our phase 2 RWJ study comparing C4P versus CCP versus a care coordination model. And although the RWJ funding alone will not get us there, we're really committed to trying to get funding to get to 1,000 patients per arm eventually, because we really think that sample size is important. As I mentioned, we've reduced the survey burden. We've also adjusted the C4P intervention to tailor the intervention to these clusters of unmet needs. And you can see here the basic clusters that correspond to the ones I mentioned earlier. For the many actually I'll start on the right again. For child-related needs, we've got an intervention we're developing with sort of more intense social worker attention, legal assistance, and a support group. For health and financial needs, issues around insurance, financial planning, counseling, and building a toolkit around this. For healthy living and social engagement, we're developing a community garden program with healthy living and cooking and that. And then for the many basic needs problem, we are developing a social service alignment learning collaborative, which Annalie is really leading. And I want to show you a little bit about, for some reason, here we skipped over. These are the organizations that we're sort of pulling together. They intentionally target all these range of unmet social needs. And we found lots of barriers to their collaboration, structural things, organizational things, turnover. But we've also found that some of these organizations are really able to transcend all of this, and one of the ways they do it is by bringing into their organizations people who can effectively function as social workers or community health workers for patients and help them navigate the system, bringing things together. So that seems to be a really important lesson from some of this. We're also busy trying to disseminate some of this stuff. At the University of Chicago, we've been migrating from fee-for-service to Medicare shared savings and other value-based contracts. We're busy expanding this to an affiliated community hospital in a very low-income suburb of Chicago called Ingalls, where we're building a C4P program. Actually got some support from AmeriCorps to help do that. And then outside the U of C, we've been working with Vanderbilt, Kaiser's Mid-Atlantic region, National University of Singapore, all of which are implementing CCP or similar programs. We've gotten some funding from Medicare through their Transformation of Clinical Practice initiative to build a learning collaborative. We're going to have a bunch of organizations engaged in that, learning about CCP and C4P. CMS has been reviewing and integrating to some extent into its plans for primary care payment models, a physician-focused payment model that could support CCP. And then we really hope to engage other institutions around the world interested in this. Two of the more interesting things most recently is we've been talking in the UK with the National Health Service about some implementation there, and then talking to Blue Cross Blue Shield at the national level and with some of the regional blues about implementing and perhaps studying CCP, C4P. So let me stop there. And also I neglected at the very beginning to just sort of thank my colleagues, Harold Pollack, who's my co-PI, and Emily Parrish, who is here, and John Curcio, who's our statistician, and Andrea Flores, who helps us manage this incredibly complex data, and a list of far too many people to remember or mention at this moment. So let me stop there and maybe turn it over to Walt, if that's okay, to tell us what it's really like.
Fantastic. Thank you, David. Yes, we'd love to hear next from Walter Kindred. Again, we mentioned at the top of the session, Walter is president of the South Shore Cultural Center Advisory Board. Lifelong resident of the South Side of Chicago, actually a professional percussionist by occupation, and as we mentioned, a patient in the C4P program, as well as a key member of the research team. So, Walter, we'd love for you to hear your thoughts about where things are, what you're learning.
Okay, well, can you hear me?
Yep,
absolutely.
Oh, okay. I'm in transition at the present time. Kind of moving around. So I've been in the program for 5 years, and prior to that, I was having a number of health issues and insurance issues as well. Because at the time, I believe you had to be 65, and I was under 65 to get in the program, and I could not get the proper health insurance that I needed. So once I turned 65 and I had those health issues, I got in the CCP program because I knew of it about a year prior to that, almost 2 years before. And I learned a lot about, I've seen it, I should say, grow in a very positive direction from the beginning. It's expanded, and it's become expanded as far as its offerings are concerned, and as far as the community is concerned. So as far as my own personal experience in using it, I've been very happy with the communications back and forth and the open communications to improve the program. And as far as the community is concerned, I've talked to a number of people in the community and also in the program, and tried to also get some of my neighbors involved in the program, because I belong to a number of organizations, senior organizations in the community, as well as the Cultural Center. And some of the people that are involved in the program now I have met through being at the Cultural Center. So, as I said, I've watched it grow and collaborate with the community and organizations in the community, and also other health and organizations. And I'm really happy with the way it's growing and expanding. And they have a team that is very professional and is working very hard to make this happen and bridging the unmet needs of the community to the hospital. So that's been very exciting for me to watch this growth. And I just hope that it can continue, because I think if it gets to the point, reaches its goal, that it's going to be beneficial for economically and health-wise for both the hospitals, not just the hospital with the CP program, but other hospitals and the community as well. That's pretty much all I can say overall, unless you have some specific questions.
Fantastic. Thank you so much, Walter. It's wonderful to hear firsthand experience with the program. And again, thanks so much to David and all the colleagues in the Chicago Collaborating Research Center for sharing us this latest batch of really exciting findings. So I think we've got maybe time for a couple of questions if we had some questions that have come in on the chat box. Let me ask Anna if there are any questions for the audience that we want to articulate at this stage.
Hi, Glenn. This is Anna here. Most of the questions we have are actually about slides right now, and whether or not slides will be made available. And they will be made available on the website in the near future. But in the meantime, if you have questions, please do be entering those in the chat box as we move through the remainder of the call. We only have a few moments, but we'll try to get to as many as we can. So we do have a question from Vanessa Karamanian, who asks, were you able to measure the unmet needs post-intervention, and did you find any significant difference compared to baseline?
Yeah, we're still a work in progress, and it's really interesting. So there are some paradoxical things. So you might have imagined unmet needs would go down, and we didn't necessarily find that. And part of we're trying to still work through the data, but one of the things that we sort of think is that a lot of times people don't even recognize they have needs until you go ahead and talk to them about things that are problems, and then they realize at that point they have needs. And so, much like the outcomes we see, there are some things where we see decreases. There are other things where we see increases. I think one of the things we have to do is kind of go through and look at the instances where we're seeing increases and where we're seeing decreases, and try to understand whether that's reflecting real changes or whether it's reflecting sort of new awareness of things. We have started to do longitudinal analyses of things like activation and unmet needs, but the cleanest way to do those analyses is need by need, and it's just getting really deep into the data. And so, and it's multiple waves that you've got to deal with and analysis. So the answer is we don't totally know yet, but when we look at crude data, there are times when we see decreases and there are times when we see increases. And we definitely do get the sense that we are helping people identify needs. Now, hopefully we can also point to needs we're resolving.
Thanks.
Fantastic.
So much, Dr.
Thank you, David. Any other questions from the audience? I know we're running short on time, but if there's any burning questions that have come in through the chat box?
We just had one come in from Maria Teresa Balbin, who asks, how were you able to collect the data on the needs? Did you resort to in-depth interview with subjects?
So we use this Health Leads instrument. And let me just talk a little bit about it because it would be easy to get confused. So Health Leads started as this student organization in Boston probably more than a decade ago. and they had these 17 questions that are basically like, do you have any a lot of little needs with respect to food, with respect to housing? They were the most general questions you could imagine. And those are the questions we used because they struck us as very, very broad. I guess Health Leads changed their screening tool a few years ago to use very specific questions. Like, for example, have you skipped a meal during the past 30 days because of lack of money or something like that? Much more specific, much more narrow. And shortly after we started the study, the original study, the original RWJ study, they switched to these more specific questions. We decided to keep the old ones for two reasons. One, we kind of like them more for our purpose, but also, of course, we'd already begun with them. And we added the other questions as well. And we've now actually got a manuscript almost done comparing the answers. And what I will tell you is the very specific questions capture a very small fraction of the patients we capture with these, and sometimes a quite different fraction. So I am not a big fan of the very specific questions. I really like these broad questions. But basically, these are patient surveys. Now, one of the things we're doing is we're trying to figure out, are there more efficient algorithms instead of asking 17 questions to try to ask a smaller number of questions? And I'll just say I was just looking at the data yesterday. Actually, one of our medical students worked on it. And what I'll say is not really for a good characterization of broad needs. But it does turn out that if there's a subset of questions you can ask, and if the answer is no to 3 or 4 of those, you can be pretty sure the answer is going to be no to most everything else. So I think it's possible in a very streamlined way to identify the vast majority of people with very few needs. And then that lets you focus. But I really think this sort of much deeper phenotyping is really important for the high needs people. And I also think it needs to continue to be done because we find wave after wave that needs there's some continuity, but there is also very meaningful change.
I realize that we are out of time and we're going to have to end the call momentarily, but quickly, folks would like to know where they might find resources related to the Health Lead Screener.
I think you can just Google it and you will find Health Lead's website. They may have taken down information about their original screener, and if you want information about that, you could either email them or email us. We're in touch with them, and we could help facilitate whatever they have on. We're also happy to send you, what we've been using, and, you could use that. As I mentioned, it's slightly different because we have the 17 domain, but we're happy to send what we have.
Fantastic. Well, again, thank you so much, Chicago team, David and Walter and colleagues. Thank all of you for joining us. Again, the Systems for Action Research Program is a research program of the Robert Wood Johnson Foundation. We do this Research in Progress webinar series twice a month. We've got more than 20 studies funded through the program, all testing various mechanisms for aligning healthcare, public health, and social service systems to improve population health. So please join us for our upcoming webinar series. Thanks so much, and look forward to being in touch. So long, everybody.
Great. Thank you.
Thank you.
Thank you.
Thanks, everyone.